Hello all and welcome to the online management group webinar. Microphones will be muted and cameras disabled on entry to webinar, but I believe some of you still have your microphones on and your cameras on. If you could help us and mute and disable your cameras now, that would be really helpful. You can also change your webinar view by looking at the settings at the top right corner and selecting speaker view. Throughout the webinar, we will be using the chat function in order to answer and ask questions. And there will be time at the end of the session for the panel to debate and explore some of your questions. This webinar is being recorded and we will share the recording after the webinar on the PPA website. If we do get Zoom bombed, we will be closing the meeting down immediately. We are not providing CPD certificates for attendance, and we would encourage you to, however, we would encourage you to promote this webinar amongst your colleagues. Thank you so much to the speakers who have joined us, and I'll now just ask for the next slide. So we have Tina and Rachel joining us regarding their experiences of a physiotherapy-led online group. And then we will hear from Diarmuid, who has led that group and some of the challenges and opportunities that he encountered. Then we will go to Dr. John O'Sullivan, clinical psychologist, and Robert Boast, physiotherapist, who will be discussing the challenges and opportunities of delivering an online intensive pain management program that they're running from Chelsea and Westminster NHS Foundation Trust. Nicola Rind is a physiotherapist up in NHS Grampian, and she will be sharing with us the development of a virtual pain management program. And then Leila Helis, physiotherapist and lead clinician and Optimised Pain Rehabilitation Unit, from Oxford NHS Foundation Trust, will be exploring the experiences with e-help and digital data collection. So I hope we have, you'll appreciate that we have a varied programme today, and I would first like to hand over to Tina Price and Rachel Bonnington to discuss their experiences as patients on a programme. Thank you.
Thank you, Claire. Claire, could you take the slide down?
Yeah.
Brilliant. Okay, excellent. So my name's Tina Price, sometimes called Christine, sometimes called Chris, various different names I go by. And just so that you know, I'm a person who lives with persistent pain. I've lived with pain for nearly 12 years now. And until COVID, all my communication, all my meetings with clinicians were face-to-face. Perhaps I can just ask Rachel, could you just quickly introduce yourself?
Yeah, hi, so I'm Rachel. Like Tina, I've also lived with persistent pain for some time now, about 6 years or so. And yeah, again, before COVID, the physiotherapy and pain management that I was involved with was all face to face.
Yeah, thank you. And just so that you know, so Rachel and I attended an online physio pain management program, actually run by Diarmuid together, along with, I don't know, it felt like there were about 10 people, but I don't know exactly how many people there were. And I think we did that a few weeks ago, Rachel?
Yeah, exactly. Just came to an end a couple of weeks ago.
Yeah, so it was a 6-week course. Diarmuid ran it because obviously with COVID at the time, no face-to-face was possible. And I think it was decided that actually, you know, video conferencing is better than nothing at all. But actually, I think as Rachel and I talk, you'll see that we're actually going to argue that COVID or no COVID, video conferencing is something that we think should go forward as an option for for patients. It was physiotherapy pain management program. There was a variety of learning, if you like. So we were delivered information, if you like. There was opportunity to talk to each other, opportunity to ask Diarmuid questions, opportunity to ask each other questions. So it was like a pain management course, but actually it happened to be online. Anything else that you can think of, Rachel, about the actual course?
Yeah, so we had sort of six sessions or so over the course of, is it 3 weeks, I think? So we had
Yes.
Tuesdays and Fridays, and I guess maybe a little bit about the format of the sessions themselves. So they were kind of largely led by Diarmuid with slide sharing, much like we've got here, with scope for I guess kind of breakout sessions. So one of the great things about Zoom is that you can have a kind of a breakout room function where you can go off with one or two other people and discuss a particular topic and then come back to the main group. And I think that bit of the course in particular was quite helpful because it allows you to kind of I guess connect with somebody else who's in a similar position. I thought that was a really valuable aspect.
Yeah, and I would echo that. So when you're actually in a face-to-face group, then you can go into a different room and so on, and that's exactly what we did. And some of the quieter members of the group really opened out, didn't they?
Yeah, definitely.
In that sort of session. But we felt that it was really important that it went ahead, because there would have been a lot of people who were just sitting on a waiting list with no support at home at all. So absolutely vital to actually give them support, really.
Yeah, absolutely. Definitely better than nothing. And also, I think there's a lot of advantages of doing the course online rather than just a kind of a telephone appointment or check-in. And I think as will hopefully become apparent as Tina and I are chatting, I think there's actually quite a lot of advantage to having group work as kind of complementary to one-to-one appointments. So that was kind of, I suppose that was one option that could have been used instead of the online group, and I'm really glad that we were able to take part in the online course.
We should probably confess, though, shouldn't we, that it wasn't without difficulty, was it?
It was not without difficulty. So we started off with the platform Attend Anywhere, so the NHS platform, which I think my impression of that platform is that it works quite well for a one-to-one discussion, but it's not set up well for online conferencing. And there were a lot of teething problems. I think one thing to say about that, I know a lot of people are quite nervous about the online format, and I think patients are really patient. People are really patient with the kind of technological difficulties that we had, and nobody complained, but I think it was a challenge, wasn't it, to not be able to hear and see people. We had people dropping in and out, and you couldn't see the slides, and there were some teething problems, but a lot of that was ironed out when we switched to using Zoom. So I think with some work on the platform,
and I suspect going forward that all these video platforms, Attend Anywhere and all the other ones, will rapidly improve, because they've been really hammered during these COVID times, haven't they? And I think the organisations are having to respond to improve them. So although we had problems with Attend Anywhere, hopefully in a month or two's time, that platform will have improved. But it made it a very interesting experience to start with, didn't it? But
it's a steep learning curve for everybody, isn't it? But yeah, I think there's hopefully a lot they can take from the feedback that we've given about that particular platform. But the course as a whole, I think, yeah, as we said, it was really good to connect with people, other people in pain, and I hope that is, you know, I think that's an important advantage of group work, because you can learn a lot from each other, and I think all of us had something to contribute, and a lot of people were quite surprised, I think, how much, even though we all have pain in different places and different kind of medical histories and things, there's still a lot in common, and a lot that you can kind of learn from other people. And how long was each session? I've just seen pop up in the chat. So about just over an hour, about an hour and a quarter, something like that.
Yeah, and it's interesting, isn't it? So going forward, I would imagine that, you know, many patients will want to go back to face in terms of group work and so on. But I can quite see that there are lots of patients, for a number of the reasons that we'll discuss in a minute, who would actually prefer that option of group work. Do you have any thoughts on that, Rachel?
Yeah, so I think definitely the aspect of group work for me, I really valued that the first time. So this was my second kind of pain management course, I guess, because I was really trying to give feedback in this particular instance. But I think that, yeah, the group aspect for me was a lot more helpful than just one-to-one in many ways, connecting with other people. But I think the online aspect as well is something that that a lot of people find really helpful, especially people who live in quite rural areas maybe, and find it difficult to get to like a hospital venue, or for people who are experiencing quite a severe flare-up maybe, or just generally not well enough to attend. I think having an online platform where you can access things quite readily without having to go a long journey. I think we spoke about costs as well, as you don't have to use public transport and things, obviously, to get there. Although there's also, I mean, online access is not without its issues, because I think we assume now that people have a ready internet connection, but that's not always the case. You know, not everybody has access to a computer and stable internet and things like that.
That's exactly. And for me, I think my ideal, so if I was going to go on a group pain management or something, my personal ideal might be to do a face-to-face the first time, so that I can actually meet the clinician in person, and I can meet the other people in the group in person. But then for me to go to a pain management group, I'd have to take a day off work, I'd have to travel, I'd have to pay the parking and so on. So that choice of being able to mix and match and so on would be hugely valuable for me, as I think it would be for anyone else.
Definitely. I think it's really about sort of flexibility and choice, giving patients the choice. I think there will be a lot of patients who would choose to access this kind of group, both while we're in this pandemic situation and beyond. I think it's there's a lot of benefits to having things online. I think we also, when we were sort of pooling ideas earlier, we talked about if you had a sort of rarer condition, you could imagine online access would enable you to talk to clinicians from anywhere in the country potentially, or, you know, join in groups outside of your own kind of area.
All right.
Oh, somebody's not muted. And one of the other things that we talked about was this was almost an ideal way of trying online groups, because there was information and there was the opportunity to talk and so on. But this particular course didn't include any activities. I think it could have done, and it might do going forward. But we had a conversation about whether we felt that actually these online groups could be used for activities. And I think our immediate reaction was, well, Joe Wicks can do it. And lots of people really going for it at the minute. So I'm guessing that actually it is possible to do the online stuff some people may not think it's as good as being in the room, and some people may think it's actually better. But we felt it was possible, didn't we?
Yeah, so activity-wise, we had a kind of a mix. So we did have some kind of homework to go away and explore the resources that were on the web link we were given for the UCLH pain clinic. And so that a part of that, there was, I guess, chance to try out some of those activities. And we did do a little kind of trial, didn't we? I think with the neck movements. Maybe you missed that one. Oh, yes. But yeah, we definitely thought that was something to expand on. How are we doing for time? I noticed there's a lot of questions popping up down here.
Yeah.
You're doing really well for time. I think we'll probably bring it to a close in a couple of minutes, because I think a lot of the questions will actually be covered by Diarmuid in the next week.
Right. So, but that's basically what we wanted to say, really. So we wanted to say it wasn't without difficulties, as I'm sure lots of you are finding at the minute, but patients were really patient and really valued the experience. And we certainly hope that going forwards, online work is going to be a choice for patients. And we certainly hope that it won't end.
Yeah, exactly.
That's a really lovely positive note to finish on. It sounds like you both got a lot out of it.
Yeah, definitely. I think even though we'd both I guess done pain management courses before, we still learned. Both of us came away learning quite a lot, and I think we were both both really valued that chance to refresh, but also to learn new things, especially from each other.
Yeah, I was going to say, and that opportunity to talk, albeit on video, worked really well.
That's a fantastic positive note to finish on. Thank you so much for sharing your experiences. I would now like to hand over to Diarmuid Denneny, who is the lead physiotherapist for the Pain Management Centre in UCLH, who is going to share the clinician's perspective of the same group.
Thanks, Claire, and thank you to Tina and Rachel. It was, it's always interesting to hear reflections back on something you've been involved in. So it's lovely to have you all here. As Claire says, I work at the Pain Management Centre at University College London Hospitals. Just to give you a little bit of context on this, what we're going to be talking about are people who are referred from our consultant colleagues, but also perhaps from GPs and from rheumatology into our self-management service, which includes physiotherapy and psychology. So before COVID happened to us all, people would be referred to us, and our first port would be to invite them to a group information session in person at our clinic. But if for any reason they weren't able to come to that, for example, English may not be their first language, meaning that a group wouldn't be appropriate, then we would meet them one-to-one with a physiotherapist and a psychologist together. So the pathway would be that people would either come to the information session and then to that one-to-one assessment with a physio or psychologist, physio and psychologist, or they would go straight into the physio and psychology assessment. And from there, it may be that they decide that this approach is not for them, or we decide that between us, and then for their discharge. But most of the time, we would, where appropriate, refer them into our multidisciplinary group pain management programs. For some people, again, groups are not appropriate, so we could offer them individual psychology and individual physiotherapy as an alternative. And after they completed these, they might be discharged from our service, or it might be that we also run an online an exercise group, a 10-week exercise group session that some people may want to come to if it's relevant to their values and their goals, and then they would be discharged. So this is just giving you a bit of context of our service. And what I'm really focusing on, and what Tina and Rachel have talked about, is this part of our pathway. So the people who were referred for individual physiotherapy, pain management physiotherapy treatment, we have, of course, been looking at an offering online for all other parts of the service now, but we're just focusing on the individual physio pathway here. So on the 20th of March, as a timeline, we had to stop all in-person appointments, like I imagine most of you have. What I did was I approached a local persistent pain support group, which Rachel is a member of, to ask advice from them. And we arranged a meeting, a sort of a focus group, as it were, with 4 members and some of the clinicians from our department, psychologists and physiotherapists, to talk about our situation. And don't worry if you can't see this, but briefly we brought to them a question: what are our options? Should we wait until we can see people face to face again? Should we direct people to resources online until they can see us? Or should we look at building something ourselves, offering online group work and individual work? And these are the slides. So what we did is we considered the options, and everybody talked, and we recorded what they were saying, either from awaiting, from directing to online resources, or for building our own. Interestingly, in the directing to online resources, one of the participants fed back their experience of how difficult it can be when you're living with pain to have to go and read through information which brings your attention more to your pain and the challenges of that. And I found that really interesting concept. So based on the feedback, we drafted up for our physio group a timetable and an information leaflet, which I sent back to the people in the persistent pain group and Tina as well, and they fed back into that and helped us to shape and to edit that. And we moved to offering our first online pain physio group. So uni professional, only people who were referred for individual pain management physio. We started that on the 21st of April. So it took a month, but there was quite a lot of work in the background setting that up. And this, again, don't worry if you can't see this, but this is the information sheet that we developed. So basically we took the Attend Anywhere format of information for patients and we adapted it ourselves. And then this is what the persistent pain support group and Tina fed into and helped us to edit. We particularly focused here on the content of sessions, and I know this is a question that has come up for you. So this was an outline of what we were covering, and in the first session, so we started with an explaining or understanding pain session, then introducing movement and activity, considering the body in health and disease, trying out movement, managing through flare-ups, and a closing session, planning what happens next. So this is a rough outline, and again, you'll be able to see this in the recording of the webinar afterwards. But also, I think it was useful to draw attention to feedback from the persistent pain group was about, tips for joining a session, perhaps putting in a diary reminder. If possible, using a big screen over a mobile phone can make it much less unpleasant an experience. Making sure that you've access to a quiet area where you can concentrate on the session, space to move, and comfortable clothing to move in. And a stable chair, we had it, this was more for being able to do the sit to stand functional measure. So a typical session will begin with allowing time for participants to join and then reviewing home practice. And Rachel's already talked about the use of the breakout rooms in Zoom, where we could send people off in pairs to discuss what their learnings, their reflections on the home practice over the week. We then present a PowerPoint presentation a bit like this on the topic of that session, and it may be that we would add to content to the slides as we were doing the session. So for example, in the flare-up session, we might say, what kind of things have you as a group found helpful? And as they would either put them in the chat or unmute and shout them out, we would type them up on the slides so that we were developing the slides with them, co-producing it almost. We then talk about what home practice would be, we would be inviting them to do between this and the next session, as well as an opportunity for questions and answers. And after each session, we would email the group with a PDF of the slides, plus links to anything we may have referenced, whether it was videos or other resources. We've completed that first group, of which we invited 7 participants from our centre, and we also had Rachel and Tina join us. One person was unable to make it, but all the others managed it. We started with Attend Anywhere, but as you've heard from Tina and Rachel, that didn't go so well, because Attend Anywhere is really only developed for 1-to-1 or perhaps at best 2-to-1 sessions. So after the third session, we got permission from our trust to switch to using Zoom only for our group work. And that was very much supported by the feedback from the participants, because I was able to use that to send to the project manager for online work in our trust. And that really helped us to have that experience and feedback from our patients. We're now in the middle of our second group. We've invited 14, but 4 have been unable to attend because the time didn't suit them. So we run it 1 hour, twice a week for 3 weeks. And that was, we chose that kind of an option based on the feedback from our initial work with the participant paying support group. We've had one person who was unable to, for various reasons, to manage Zoom, but they have since been practicing with their grandchildren and are planning to join our next group. Evaluation is key to this, and I know that's something that Leila is going to be talking a bit about later, so I won't spend too long, but this is, as part of evaluation, my colleague Jackie Walumbe, who's incidentally, she's the vice chair of the Physio Pain Association, but she's also doing her PhD, and she's been interviewing some of the participants from our first group. And this is kind of some of the feedback, which I think echoes some of the things that Tina and Rachel have already said. You know, until we went to Zoom, it was hopeless, is a direct quote from one person. So that gives you a sense of how much people enjoyed or not using Attend Anywhere. It's not really for group work. There's this sense of enjoying it, but also enjoying meeting other people, like Rachel talked about, and a sense that it's a great tool to use online. Again, really, these are just echoing what Tina and Rachel have already said to you. So I think what's also interesting is this talk about access and how it can be perhaps more accessible for some people who would otherwise find it difficult to get to a central London venue as ours. So most pain centres are often sited in the middle of city centres or whatever, and not particularly accessible. So my reflections on this is that this was our pathway for people who had been referred for one-to-one treatment, and yet we were offering them a group. So we were going to be, we were interested to see how people might feel about that. Interestingly, people immediately enjoyed and found the chat function very useful in the group sessions online. And what I've noticed is that, exactly as Rachel had mentioned, and I think Tina also, that some people who perhaps would sit quietly in a group and not converse very much seem much more comfortable about using the chat function to engage with the group and to feed into it. So that was really noticeable. The breakout room function was a crowd pleaser, for want of a better term, and a really useful tool to be able to use, which unfortunately is not available in all platforms. So that's something to think about. There's a big concern around, you know, security and governance, and we've even talked about it here around Zoom bombing, for example. So that is something, my experience has been that it's something that is perhaps more a concern for clinicians than patient participants. And of course, we need to have, you know, make sure we have the correct governance in place when we're considering any service developments and service changes. But obviously, during the current pandemic, that's been something we've had to kind of look at maybe in different ways. Related to security is this risk of Zoom bombing. So far, we've been Zoom bombed by various animals, I would say. I've had a sheep or a lamb in one session. I've had chickens in another one. There's lots of cats and dogs. I'm sure you've all seen them in programs. The other Zoom bombers are babies and family members, and that's maybe something to consider in terms of what you may be discussing in groups and how appropriate it may be for if, for example, a participant is there with their loudspeakers on and the content of discussion. So it's just something to be aware of. As Tina and Rachel have said, movement is something that we think can be done. And my colleagues, Rachel and Joe, Rachel Stavell and Joe Moody, who may be on the call, I can't see them, but they run our exercise group called Activate. And we've been running that online in group sessions as well. And it seems to be working really well. And it's nice to see people moving in their own homes and get a sense of how that is for them. And yeah, as Tina and Rachel said, one thing we've reflected on and started to change from our first iteration to the next group is to incorporate some more movement activity and breathing awareness and things like that into our sessions. So, but again, evaluation is something really important for us all to be thinking about. And in terms of how we collect our measures, as you saw, we also didn't, in our first feasibility trial, the smaller group with Tina and Rachel present, we didn't capture sit to stand. We have since started doing that, and it works quite well, both in our physio group, but also in our MDT online pain management program that we've also started and are due to finish soon. This is an example of a slide from our first session around, you know, group agreement, as it were. And so we talk about things like what will happen if you freeze or drop out of the session. Talk about there'll be opportunities for questions and answers. We, much as we did at the beginning of this, we show people the mute and the camera buttons and the raise their hand function. We talk about how and when to use chat. We have to remind people that it's illegal to record or to take screenshots. And that's something that comes up automatically in Attend Anywhere as part of the terms and conditions, but not with Zoom, for example. But there's obviously a confidentiality issues where you can see everybody's name. So it's important to remind your group about that. And just that concept I said of perhaps other people being present in the background that you may not see, and just that we cannot control for who may be listening in on groups. So just things that we talk about. My top tips, and I'm sorry I'm flying through these, is where possible co-produce with the people you're going to be working with, your patients. I think that just really helps to help you to develop something that's going to be more relevant and useful for the group that you're working with. It's really important to understand your own team and the anxieties, and I'll put my hand up and say that's something that I perhaps misjudged starting out. I've been using Zoom, for example, for the last year or two, and are quite comfortable with it, but I sometimes forget that not all of my team colleagues, and I know if they're in the group, they'll tell you that too, they may think I sometimes assume that we're all very comfortable, and we're not all comfortable, and it is a different way of working. You know, so thinking about what training requirements might be needed. What we started doing was hosting some of our team meetings on the platforms that we were using, just to become familiar with them and to practice things like screen sharing and those types of things. What hardware needs might they have? Cameras, screens, larger screen, for example, and the privacy issues for your staff as well as for participants in the groups. Always allow extra time. I think John and Rob will be talking about what they're doing for their groups, but the first session will always take longer because there will be a bit of connection issues and coming to grips with cameras and things like that. Our sessions were, we thought we could do them in an hour, but I think realistically an hour plus 15-minute buffer at the end for questions and answers and to run over is probably a good amount of time with some breaking up in that. There are lots of admin implications to online groups. How we book, our booking systems, and how we can incorporate in that we're booking people onto video consultations. That's something we're still grappling with. How we collect our outcome measures, which I know, again, Leila will be talking a bit about later, and how we convert those to online that participants can access and fill in easily or relatively easily. And how we share our slides and things at the end, the admin of emailing out and that. This is all extra perhaps work that you mightn't have had to do if you're in a face-to-face or in-person group. Technical support is vital. Get to know your video consultation project manager in your team. Ours is called Oliver, and he's been amazing and really helpful. And we were an early adopter site in our trust, so that was an advantage because we had his ear regularly to try and help us with some of the issues and the tech issues. Also, do not forget about governance, and whatever you choose to use, it's really important that you involve the relevant governance permission people in that. And it's okay not to be perfect, as Rachel so lovely said, you know, we'll get it wrong. I've had to run out of the session because my earphones were ringing and go off and find another pair and come back. You know, these things happen, or animals appear. It's okay. It's okay. Just let people know I'm struggling right now. I can't find the slides. It's okay. I just wanted to end by saying thank you. Thank you to all of our patients who've really been willing to go with us on this journey and learn this different way of working and be patient with us. To the persistent pain support group at Camden, and to Rachel and Tina for being engaged and being involved and giving lots of feedback to help us to improve it. To Oliver, who's our IT support man, and to my team who've been very patient with me as I've been championing moving this forward. So yeah, thanks. How am I for time?
That's great, Diarmuid. I'm not going to talk about your time. Dr. John O'Sullivan, clinical psychologist, Robert Bose, physiotherapist from Chelsea and Westminster Hospital's NHS Foundation share the challenges and opportunities of building an online program. So I'd just like to hand over to them.
Yeah, thanks. Thanks, Claire, and thanks to the PPA for asking us to share our experience. I'm John O'Sullivan. I'm a clinical psychologist. I work at Chelsea Westminster Hospital. I'm here, well, not corporeally here with my colleague Rob Bose, but virtually here with my colleague Rob Bose, who's zooming in from home.
Afternoon, yeah, I'm Rob, yeah. Right.
We're going to talk to you about our experience of delivering an intensive virtual pain management program, and talk to you about the exercise component of that program and the other virtual programs we're running currently during COVID. Not that we call it an intensive virtual program, it's but by the number of contacts per week, it does seem like we're doing a little bit more frequently than our colleagues at the moment. And we'll talk about the structure, the content, the challenges that we've faced, and some reflections and tips for you as well. So that's Chelsea there, and at the moment it's got some very lovely flowers donated by a local florist during the COVID crisis. So pre-COVID, what we would normally do would be running, in terms of group programs, would be holding a 7-session pain management program, which totals about 35 hours. We have a 10-session strength and relaxation program, which totals about 15 hours, a 12-session exercise class, a 5-session yoga workshop run by Rob, plus other provision for specialist services, including survivors of torture, spinal cord stimulator, and Arabic women's PMP, as well as a charity-funded gym club that's run by one of our colleagues, Dan. Now, during COVID, so Dermot, to give you the timeline for UCLH, pretty similar at Chelsea, we stopped in-person contacts around the middle of March. And since then, I've been developing a 12-session virtual PMP for total around 18 hours of input in total, as well as Rob's yoga workshop going completely online. And with the return of Dan, our colleague, from being redeployed, and the reinvention of a gym club, which is a 1-hour rolling virtual evening class. I won't spend much time on this because our pathways are pretty similar to UCLH's, but we have usual pain clinic referrals from our in-house pain clinic to our therapy service. So if they're going to attend our service at the moment, they will Zoom in for a virtual pain education session. They'll be introduced to pain science education and the psychological model of working here, which is acceptance commitment therapy. I suspect many of the services around the country already know what that means. I won't go into too much detail about it. That's 1.5 hours. From there, we ask people to opt in. At the moment, an email opt-in to our team at nhs.net account. And we'll move them forward then to a virtual pain management program assessment, where they'll meet with the psychologist and the physiotherapist again via Zoom. It takes about an hour. So following that pain management program assessment, if we think that they would benefit from our online or virtual pain management program, then we put them through the VPMP pathway. So that commences with a 1-hour meet and greet session. So that was thought about really to tackle some of the technological issues that we anticipated coming up against, certainly from our side of things, as well as patient side of things. But also to socialize people into meeting each other, because it's a group experience, and to socialize them to the types of functionality that we'd be using via Zoom. So the breakout rooms, which have been mentioned, also an external website that we use to consolidate learning called Kahoot, and I'll talk about that again in a moment. And then following that, they commence the intervention proper, which is 12 sessions and a 90-minute session 3 times per week for 4 consecutive weeks. So the first cohort are midway through their intervention at the moment. They meet on Monday, Wednesday, and Thursday mornings, primarily because of clinician availability. And our second cohort, which was due to launch today, but there were some problems and will now be delayed for a further 2 weeks. They'll be meeting on Monday, Wednesday, and Friday afternoons. Each cohort's capacity for 8 patients. In the first cohort, we are running with 6 at the moment. And in addition to having an experiential pain management program, albeit online, they are provided with a comprehensive workbook and receive support from our YouTube channel. It's a little glimpse of the workbook, which will contain added information about the sessions, each session that we have with people, as well as extra appendices around the movement component, which is yoga, and the relaxation component that runs throughout, as well as the sleep intervention that runs throughout the program as well. It's a little screenshot from our YouTube channel, which we've had up and running for about a year now, and are leaning heavily on it as a resource for our online and virtual pain management program. Following the 12 sessions, then we're inviting people back for a 3-month and a 9-month virtual group follow-up. That would be comparable to what our in-person pain management programs would include. And we're planning focus groups for cohort 1 and 2 so that we get service user engagement, their feedback about the content, the delivery, anything that we can learn from, and of course be analysing proms as well. So it's delivered. We, like UCLH, are using Zoom, and just as Dermot was talking, I could see a lot of questions asking how people were able to get agreement from their trust about Zoom. Ours happened more by accident than design, in that we were also being moved towards Attend Anywhere. The connectivity problems at Chelsea meant that our business innovator, who's charged with delivering it to the Chelsea site, said that it's just not good enough at the moment and we need something to interact with patients, and we switched to Zoom. Given that we're early adopters, we were quick enough to buy a license as well, so the trust were able to provide us with a year's worth of license. And I can see people asking about how we can, if we can share anything that they can go to their trust with. I'm not sure if we've got anything as formal as like a document that we went to the trust with, only as an agreement and saying that we needed something. The resource at the moment, there's 3 clinicians needed to facilitate the PMP. The clinical psychologist, specialist pain physio, and assistant psychologist. 2 facilitators on camera, and an assistant psychologist who's co-hosting off camera to provide support, technological support to patients and to us as well. And the functions that we're using, primarily the screen share, which we're using here, we are leaning on an experiential practice. So the movement component is experiential, as well as the mindfulness components of the ACT intervention. And the small group discussion, which when we started this, we thought would feature only as a little part of the PMP, is quickly turning out to be something of, what did Dermot say, a vote winner, and certainly something that's being valued by the first cohort. When using, so I think in person groups, we rely quite a lot on humour and levity in the groups, and we're using Kahoot, which if you're anything like me, you'll be doing quizzes at home with friends. And we're using that in terms of consolidating learning from session to session, as well as providing between session email support to the patients in the VPMP. Right, so each session, the components include grounding exercise or a mindfulness practice, consolidation of learning, like I said, using the like a quiz via Kahoot, and the breakout rooms so people can talk about how they're putting into practice the strategies that we're learning. We then have a physical component, and for cohort 1, that's yoga, led by Rob, and for our second cohort, it'll be a functional exercise program with the flexibility to include Pilates and Tai Chi. That's because of the skill set of the clinicians facilitating them. Relaxation strategies, which are taught early on and feature throughout. A sleep intervention, which is based on the sleep book by Dr. Guy Meadows, ACT, Consistent Intervention to Improve Sleep Opportunity. Each session has a modular topic. I'll show you what they look like in a second. And each session finishes with committed action. So ACT, Speak for Behavioral Activation, and SMART goals. So this is session 2, I believe. And if you look down the timings there, so 10-minute grounding exercise, 10-minute reviewing home practice, which includes breakout rooms, the quiz, 30 minutes for yoga, 20 minutes for the learning for the module, and this one's a relaxation strategy, 10 minutes for setting committed actions, home practice and close. Now, if that looks like a tight 90 minutes, it's because it is, and certainly we find that time is flying when we're on each session, and it'll be interesting to know when we do the focus groups what that feels like for a participant. They're the 12 modules, so sessions 1 to 12, beginning with pain science education, which they've already had a little bit of because they've attended our online virtual pain education session, through to relaxation strategies, introduced to the sleep intervention in session 3, and have an accompanying appendix, so that the emphasis of home learning and progressing that. And why exercise is important for people with persistent pain, or important for anyone who has a body. Primary and secondary suffering, or clean and dirty pain, if you want to think about it in terms of the psychological model. Choice point, which is very act congruent. A topic on compassion, which is a little bit drawn from compassion focused therapy. Communication skills for people with pain. We have one of our registrars who has not yet delivered, but promises to deliver a Q&A for medication and persistent pain. And then we come to the back 3 sessions, which are focused towards building a toolkit for people, so that in the short, medium and long term, they feel like they're able to manage their pain. So finding balance in life between love tos and have tos, managing flare-ups and setbacks, and then thinking about long-term management and introducing them to our local persistent pain support group, which is called SMILE, and used to live just down the road. I presume they're going to do something virtually in the peri-COVID time. So challenges and reflections. So I think Diarmuid touched on it, but having availability for correct hardware. Our hospital, I imagine, like most other hospitals over the last 10 to 15 years, didn't invest an awful lot of capital in terms of hardware. So finding the right computers with the right software, the right cameras, and the right room is a challenge, and continues to be a challenge. The functionality of the software. So since we have started this cohort, we now know that Attend Anywhere has better connectivity on the trust site, and are waiting for the connection between us and the trust, where they might insist that we use Attend Anywhere. And then what we will lose by using Attend Anywhere, like the functional options of breakout rooms. Technological mishaps, it happens to us too. So only yesterday, where we were hosting the session and we were kicked out of the room because of a network glitch, and then we returned to the patients happily talking about where we had gone. Digital literacy of clinicians and of our client group, and where possible, trying to skill people up to make them feel more confident to use something like this, because it will probably be part of the landscape going forward. It's interesting to hear Diarmuid say that the admin side of things is quite resource heavy, and we're certainly finding that. And there's little, at the moment, infrastructural support within the hospital in terms of appointment reminders, or sending out links and emails and letters and the rest. We found as facilitators that we're having to adapt our facilitation skills, and we're learning the whole time. So in person-to-person or in-person pain management programs, I think we're rather open and let the group process take hold. Whereas on Zoom, we're a little bit more didactic, asking to hear from patient X or patient Y and how their experience has been. And certainly that's certainly part of the time management issue that we're noticing in our sessions. And yeah, and if there was a tip that I'd give you from this slide, be using, if you have the ability to use breakout rooms, don't be shy to, because I think it is adding an extra layer to patient experience in the VP. So you'll have heard about Zoom fatigue, because it's cognitively demanding in a different way to communicate like this. And also we're doing something new, but certainly after every session at the moment, the 3 clinicians are looking at each other absolutely exhausted. And I wonder if it's the same for our participants. So we're an intensive virtual pain management program, as the title says, but at the end of the focus group, whether that is too much too soon for people, or actually are they saying that, you know, I appreciated the short time between each session, because it's a little nudge every other day to keep it present in my mind. Well, this we'll find out. And like everyone else, we're interested in the efficacy of this and madly collecting proms, and doing so in quite a prosaic way. So if anyone has a sensible and straightforward way of collecting proms digitally, which seems to satisfy the IG around that, we'd be interested to talk to you. And then, yeah, the focus group we're looking forward to already, engagement with service users. Of course, it won't be the facilitators asking those questions. We'll be getting someone else to ask, so that they would speak as freely as possible. And then this, where we get to collaborate with other services and find out what you're doing, because we're dead interested in learning from our colleagues. So I'm going to hand over to Rob, who's going to talk about the exercise component of our virtual programs.
Hi there, thanks John. Yeah, so my name's Rob Boast, and I'm one of the pain physiotherapists who's co-facilitating the virtual program alongside John and also our colleague Dr. Emma Burgess, who's one of the clinical psychologists in our team also. I'm going to briefly talk with you about running virtual group exercise programs. Now, there's only a brief section on this. So we do have our YouTube channel, Chelsea Pain Clinic, which if people are interested in visiting, give you a bit more kind of breadth and ideas about what we're actually offering at the moment. And also, if anyone wants any further information about the specifics about what I'm talking about today, then please feel free to get in contact, perhaps via Claire, and I'll happily disseminate further information about what we're doing. As a team, we felt it was really important to continue offering group-based exercise moving forwards during the lockdown. There's a number of reasons why yoga was the kind of the mode of exercise chosen. I should say that I'm also a yoga instructor as well as a physiotherapist. I was also the only physiotherapist out of our team of Dan Board and Gavin Walsh not redeployed to ICU. So my skill set tends to bias towards yoga. Also fits quite nicely with the ACT framework. And also fortuitously, prior to the pandemic, we'd developed our online platform, YouTube channel, Chelsea Pain Clinic. Therefore, we had a number of kind of videos pre-uploaded onto there. And I'd already been running face-to-face for some time a yoga workshop for people living with persistent pain. And part of the yoga workshop was the online content. And so it was kind of a semi-e-learning process anyway. So it fitted quite nicely into delivering online content. We felt that part of the virtual pain management program, or a significant part, 30% of it, should be an experiential process. So obviously thinking about things like mindfulness, which are a bit more easily delivered virtually, but also groups participating in activity and exercise. So we offer that as 30% of the virtual pain management program. And it's 12 30-minute sessions. On the next slide, I'll talk a little bit more about what that looks like. Also at the moment, offer, rather than face-to-face, I offer the yoga workshop virtually as well. So that is a standalone intervention after an assessment by myself. And it's 5 2-hour yoga workshops, which is delivering graded yoga-based breathing, movement, and meditation exercises. John, if you can, next slide, please. Okay, so thinking very briefly about what I teach in the sessions, and like I said, if you need further information, I'd be happy to disseminate that. So essentially, I wanted to deliver something that was a graded exposure model to activity. So rather than repeating the same exercises each week as the group, or following something online that was pre-recorded, be an experiential process where, as well as thinking about that top-down approach to helping people make behavioural change and improve their confidence to live with pain, is also thinking about that bottom-up approach. We also know that people are more likely to continue on something that they actually enjoy experiencing and are practicing in the moment, rather than told to do something or being directed or signposted elsewhere. So essentially what I offer is in the virtual pain management program, it's the same as the yoga workshop, but it's split over 12 sessions and graded in a much more gradual way per session. But I deliver it, the only piece of equipment that is required is a chair. And that has important contextual reasons, as at the moment, often people don't have access to equipment, not allowed to go to gyms, lots of social distancing, and they might not have any equipment at home. And kind of a 500-gram tin of beans has some limitations in terms of improving kind of functional gains. Trying to develop something that was in line with what we're looking to help people improve by attending either the program or the workshops. Things like their function, their strength and conditioning, their mobility, flexibility, their confidence to live with pain, and their mental well-being. So each session builds upon the previous one in a graded fashion, starting with a chair-based seated, then a chair-based standing practice, and then moving forwards onto a self-assisted standing and a kneeling and mat-based practices. Okay, and next slide, lovely. So thinking about the context really. So I might add, I'm not on the board for the HCPC or the CSP. This is more as a clinician. These are my reflections based on my experience over the last 10 weeks, essentially. So prior to setting this up, I was thinking about the context in terms of what we're in and the HCPC's recommendations. And I was thinking about that balance between the harm of not delivering a treatment compared to the harm of delivering a treatment. And then it's weighing up the risks, essentially, of delivering a virtual group-based exercise program. So, for example, the risk of falls, the risk of having a cardiac event during exercise virtually, or that, like we've been talking about, the information governance risk of perhaps someone recording something. And really, it's kind of thinking about, are these risks really any greater or harder to mitigate than if this was face-to-face? And I think with good preparation, next slide please, John. I think with good preparation, then actually, no, not really. Obviously there are things to consider, but it's still easy enough to mitigate as many risks as possible. So being prepared is key, really. And probably for many of you, this is kind of telling you how to suck eggs, but developing an SOP in the first instance, so standard operating procedure, and also designing your exercise around obviously the population that you're teaching it to, so people living with persistent pain, but thinking about how you're delivering it, i.e. virtually. You can't just copy and paste what you teach face-to-face over to a virtual setting. It's not quite as simple as that. So really thinking about how you might design something to be effective and also safe to deliver and practice at home. So also thinking about whatever setting you might work in, whether it's in secondary care like us or in the communities, having good access to full medical records and information gathering. This is really essential, especially when you're not with the person when you're teaching exercise and you don't have access to an oxygen machine, for example, to take their blood pressure or heart rate or oxygen levels. So ensuring that you've got a good access to their full medical records, really have a good understanding of their cardiac history example. And then understanding the limitations of the assessment. So as John said, after the information session, each individual will have an assessment by a psychologist and a physiotherapist prior to any form of treatment. Now, virtually, we can assess obviously a subjective assessment and an objective assessment. You can see someone sit to stand from a chair, you can see the mobility of their joints, and to a degree you can see their strength, but you can't truly physically examine and test their strength and sensation. So taking those limitations into account when referring a patient onto an intervention, but also who you would accept and only accepting appropriate referrals for your virtual sessions, and ensuring good information governance. So like John said, we don't have that infrastructure at the moment for, we don't have administrative teams, don't have receptionists. So we're doing a lot of the kind of checking in, checking out and information governance prior to seeing these patients. So it's really paramount that you have their correct address, telephone number, GP address. For example, if you were to teach a group of people exercise and then one of them collapsed, you need to ensure that you've got their right address if you're going to then call an ambulance. And in touch with that hasn't happened so far, but it's really important to consider. And obviously the increased risk of someone recording something, but sending out pre-information about IG and GDPR is really key, like Diarmuid was describing. Yeah, next slide, please. Okay, and making sure that the patients are fully informed prior to attending any form of group-based exercise. So we obviously have patients going through the group pain information sessions, so they have a broader understanding as to their pain experience and the normality of the things that they might expect during and after exercise, and understanding their pain in more depth, but also understanding the intervention that you're offering in good depth, because you're not necessarily there in person to help them understand that. Making sure you're well resourced as well, which is, like I said at the beginning, one of the reasons why yoga was chosen is because of the comprehensive workbooks, the handouts that you have online anyway prior to the lockdown, and the YouTube channel that we have. Okay. So, sorry. Oh, yes. So it's also thinking about the inappropriate platform. So we spoke multiple times about the limitations of Attend Anywhere and the kind of improvement Zoom offers to a group-based intervention. However, one of the things to consider here is that Zoom, you can have multiple people effectively joining a session, but you can't necessarily effectively observe multiple people. So one of the reasons why I've kept the numbers lower, for example, in the yoga workshops being 5, is because I can effectively observe 5 people at any one time virtually. There are still limits to that. So having a co-host is really helpful. So our assistant psychologist, Cassandra, has been co-hosting the session. So they act as administrator, able to communicate during the sessions, but also they're a second pair of eyes if you're stood at a distance from the screen. So that's thinking about your environment also. So ensuring that you and your patients have a safe environment, also a private environment, and the right equipment to be able to perform the exercise at home effectively. But also thinking about having effective video, camera, lighting, and sound. It's quite difficult to ensure that all your participants, all your patients are in view all the time, especially when you're moving perhaps from chair to standing, then down onto the floor, kneeling, and down onto a mat. So ensuring that they're changing the position of their camera during the session, that their lighting is good enough so that you can always see them, and vice versa, they can see you. But also, when you're teaching exercise, you often have to teach it from a distance from the microphone. So unless you've got a wireless headset, that can be important to think about your room. So a too big a room means the acoustics aren't very good for developing exercise, although the space is good. So there's all these things to kind of be thinking about when offering group-based exercise. And then final slide, please, John. Finally, just like to say thank you to the PPA for offering this webinar today and allowing us to speak at it, and also to all our patients currently going through the virtual pathway. And a big thank you to all our colleagues in the pain therapies team, and a special thank you to our excellent clinical psychologist, Dr. Emma Burgess, who not only wrote a lot of the content of our virtual program, but also is co-facilitating it alongside John and myself.
That's wonderful. Thank you so much for sharing that, Rob and John. Really appreciate you being so generous with your experiences. I'm now going to pass over to Nicola Rind, who is based in NHS Grampian as an advanced practice physiotherapist in pain management. Nicola. And Nicola, I'm not sure we can hear you.
Can you hear me now?
Yes, we can.
Yeah. Okay. Sorry, I've been having a few technical difficulties. I'll take my mic off and hopefully you'll hear me now. So as you've heard from the other speakers, we again were in the situation of thinking about how do we deliver our pain management programs during the current situation. And in case you didn't hear me at the start, I'm Nicola Rind, one of the physiotherapists working in the pain management service in NHS Grampian. So the programs that we had previously been running were based on the ACT format. And we previously ran a full pain management program and a brief group that was 4 weeks duration. So we decided initially to base our virtual PMP on the 4-week format. We did this for a couple of reasons. Firstly, the uncertainty of knowing how long we were going to be delivering on this type of format. And secondly, we thought it would give us the opportunity to assess both the feasibility and acceptability of running a virtual program, both for participants and for clinicians. So we used the ACT matrix within our pain management programs, and we thought it was a good fit for the delivery of the 4-week program. So week 1, we focus on workability and creative hopelessness. Week 2, we focus on values. Week 3, pain and thoughts, control and avoidance. And then week 4, committed actions and activity management. So in terms of how that looks, this slide gives a wee bit of an idea about what the programme is like for the participants. This is a timetable from one of our previous face-to-face brief groups. So in those groups, we would have a mindful movement component and we would have mindfulness exercises as well. So we recorded both those components, the mindfulness exercise in audio and the mindful movement videos. We recorded a Qigong sequence and seated Pilates, and both of those are emailed out to the patient as part of their weekly content. So each week, as in addition to those two components, there's a talk, which would previously been delivered usually by a PowerPoint. So we have slightly modified those talks and added on some audio. And you can see the table gives the list of the talks for each week. And that again is emailed out to the patient. So the interactive part is the weekly workshop, which is delivered over CMS. And like I say, that's an interactive format, and based on the topics you can see there on the table as well. And each week the patient has a weekly telephone consultation so that we can follow up on what has been delivered both in the workshop and via email, and to try and personalise the content as well. So essentially this is what one of the groups might look like for the participants, and sort of a timeline for us as well. So we're currently on week 2 of one of our groups and week 1 of the other group. We have 4 members of staff, 2 physios and 2 clinically applied assistant psychologists, and we have a physio and a psychologist delivering each programme. So initially the patient will have a screening call, and the patients that we're phoning are people who have already been assessed for a pain management programme and deemed suitable, and they were previously sitting on a waiting list when COVID happened. So the screening call is really to re-establish, are they still willing and able to engage with self-management? Are they happy with the online format and have appropriate technology to engage? We discuss confidentiality, particularly around the workshop. We're completing one outcome measure, patient-specific functional scale, and then confirming obviously they can attend the weekly workshop and the time of the telephone review consultation. So following that, they'll be sent an email with a video about what to expect from a pain management programme, and the questionnaire packs for the baseline measures. So we're looking at TSK, CPAC, DAPOS and EQ5D. So they're emailed out in a format that the patient can complete and return to us by email. So the current group that's running on week 2, they have their weekly content emailed out on a Friday. So that's their PowerPoint talk for that week with the audio, a link to a mindfulness audio and a link to a movement video. They're given the relevant section of the workbook, and the date and time of their workshop is confirmed with the link to copy and paste into the browser. Then for this particular group, they have their workshop on a Tuesday, which lasts an hour, and then the following day they have their telephone call, where we're looking at reinforcing the key messages from that week, discussing any concerns they might have, trying to personalise the content. So for example, week 1's workshop was on workability. So over the phone we'll be looking at establishing a personal workability table and what conclusions does the patient come to around their own workability. And the telephone call is half an hour. We have structured the consultation around an evaluation form, which is collecting qualitative data. So following that, this format is repeated for 4 weeks. And then there'll be a 3-month follow-up telephone consultation where we repeat the baseline measures and obviously look at maintaining gains. So referring patients on for our Grand Pain support group and linking them in with Live Well, which is Sport Aberdeen, where they can access local activity groups that are running based on their level. So the format that we currently have for that group, where they have the workshop on a Tuesday and a phone call on the Wednesday, already we're getting the feedback, as we suspected, that they're a little bit close together. There's not enough time for patients to necessarily have gone through all of the content. The staff that are currently running the groups, we're still partly redeployed. So I think ideally we would space that a little bit more so there's more time to for participants to digest the content. So obviously we're early days and our numbers are particularly small, but just to give a bit of a snapshot of some of the qualitative data that we're collecting and what our response and feedback has been so far. So for the first group, we screened by telephone 11 patients. 2 were no longer wishing to engage in a pain management programme and were discharged. 1 requested a face-to-face pain management programme, so they remain on the waiting list for that. So we recruited 8, and unfortunately 2 didn't attend the first workshop, and 1 was subsequently asked to be discharged at the telephone call, and 1 patient forgot and is keen to re-engage back in. So following that first week's content, in terms of the evaluation we are doing, we're looking at both the content of the programme we're delivering and also the acceptability of the format, the online format. So a couple of questions around the content. Was the topic relevant, and did the sessions help the person to identify a goal relevant to them? So 6 of the participants said yes, the topic was relevant, and with regards to identifying the goal, for 5 yes, that was the case, and 1 not the case. In terms of the actual the new format, the online format, when the patients were asked about their confidence in accessing the workshop, 4 of the 6 were very confident accessing the workshop. 1 felt somewhat confident and 1 was unsure. However, all 6 felt the workshop was either useful or very useful. And with regards to some of the specific feedback around that, it echoes what we've heard already this afternoon. People felt it was good to sit and listen to others and feel that I'm not the only person living with pain. A few people have said similar comments to that. 1 participant said, I'm surprised because I'm a shy person, but I was comfortable to speak. I think I felt more secure because I'm in my own home. And someone else agreed, saying they felt at ease in the comfort of their own home and less socially awkward. 1 participant who was unsure about engaging and said, it felt strange to speak into a microphone and not be able to see people in real time, but they felt the gain from hearing others speak. So I think initially we were quite surprised at the positive feedback that we received, because we had concerns about that loss of the shared experience by delivering the pain management programme in this format. So just to finish off, a few sort of points to consider and things that we have picked up as we've gone along. I mean, we are learning as we go along in response to patients' feedback. One of the key things is confidentiality in the workshops. So obviously we, at the telephone screening consultation, we make sure the patients are aware that they should be the only person seeing the other participants or hearing the other participants in the group. But of course there's no way really to police that. So we also say, as part of the group agreement, that bearing that in mind, that people should only share within the group what they feel comfortable to share. One of our main concerns was around this loss of shared experience, in that there wasn't that face-to-face group environment. However, the feedback we've received so far, has reassured us that that doesn't seem to be the case. And in fact, some people are saying they're more likely to engage and more likely to participate in the workshop because they feel more comfortable being in their own home. However, to mitigate that, prior to getting the feedback, we altered our workbook to weave in a patient's story so that there was still that shared experience in some form. I mean, I think as people have said, patients with technology, we have been moved out of our usual hospital accommodation, and where we are, the Wi-Fi is not great, and actually we were thrown out of the workshop several times and had to join back in. So, just, I suppose there's no way to prevent that completely, but just to make participants aware it might happen and what to do if it does. The 2 groups that we have running, myself and one of the psychologists that run them, we are in the same room delivering the workshop. The other 2 are remote from each other, and each has its positives and its benefits and its distractions, because when you are separate, if one person gets thrown out, the other person can continue the workshop. So although we thought that wouldn't work, that seems to have worked quite well. Some of the feedback we've had already from patients was that an introductory workshop would be beneficial, because it allows you a chance to try out the technology, and any problems you might have, you can iron them out at that sort of meet and greet session, rather than perhaps missing some of the content, particularly because it is only 4 weeks, our group. So that's something we're going to take on board as well. With regards to the length of the programme, 4 weeks is quite short. There is a question of how much change can happen in such a short period. Like I say, the reason of choosing the 4 weeks were the considerations around how long we would be delivering in this format, and to give us a chance to look at feasibility. But it would be our intention to lengthen it to an 8-week programme, where there will be a workshop in week 1 and a phone call in week 2, and it will follow the format like that, which I think will address some of the concerns that participants have had around being able to digest the content in such a short space of time. I would advise doing a test workshop first over whichever platform you're using. We had intended to use a flip chart for the workshops. However, it was impossible to see, so we do what we're doing now, a shared screen where there's slides that we can type on to make it more interactive, depending on what the patient's feedback is. And with regards to evaluation, we're working closely with the QI team to evaluate the programme, and we are using the QI 3-step format for that. So I've taken out my last slide, which was any questions, because we're not doing that at the end of each presentation. So we can pick up on any questions later on. So thank you for listening. I hope it's been helpful to share that.
That's great, Nicola. Thank you so much. I think I've just put a question there asking what QI is, but obviously it's quality improvement. Thank you, Nicola.
Yeah, quality improvement, yes.
So I'd now like to hand over to Leila Heelis, who is the lead clinician at the Optimised Pain Rehabilitation Unit in Oxford NHS Hospitals Foundation Trust. No, Leila, I don't think we can hear you.
Apologies, sorry. I'm aware of the time, so I'm just going to give a very brief overview of our experiences of using e-health, which I mean is digitally delivered health education and or sharing of health resources, and also talk about digital data collection. So whenever you're undertaking a quality improvement initiative, it's good to have a look at existing literature. So I looked at this systematic view for web-based interventions for pain. And it was quite notable that very few studies included any exercise or graded activity component. And there was limited data in the paper about baseline physical function levels or any baseline measures. And there are also methodological issues with quite a few papers in the paper rather. And then looking at the results, they were less than impressive, to be honest. However, the web-based interventions, both of which included tailored components, which included email follow-up or talking to participants on the phone or face-to-face, they found that whether it was compared to standard care, such as being on a waiting list for a pain clinic, that led to a small improvement in pain, but not in any other of the outcome domains. And when compared to active control, which could have been a face-to-face intervention, there was a small beneficial effect in catastrophizing over the active control. The authors of this systematic review are going to update it, I believe, and I think further research that's been published more recently might be more positive. So I looked at some of the more recent research, specifically papers that looked at the type of intervention that I wanted to deliver. So basically participants work through modules on their own at home, and then they have some time with a physiotherapist talking on the phone or a video call. But in these studies, they had email contact with psychologists. And looking at the participants, a lot of them had been recruited online. So it may be that they were more of a tech savvy cohort. And also that in one of the studies, they didn't have anxiety or depression at baseline, and a high number of the participants were employed or well educated. So just to be mindful that it may have been a particular cohort, and that we need to be aware of perhaps inequalities in how we deliver our services. Most interventions that I looked at were between 6 and 8 weeks long, and I was particularly interested in the Lin et al. Study because it used an acceptance and commitment therapy model, which we use in our service, and the outcomes were good in terms of their effect sizes. However, there was a high level of dropout. Now, the Lin et al. Study included baseline measures, and there were 3 arms in that trial. So I've included the range of baseline scores, and they also map quite nicely into data that we collect for a Get Back Active group. Our Get Back Active group is a 45-hour intervention, and it's aligned with a combined physical and psychological program, which has been described in the NICE low back pain guidelines. And you can see from this that the baseline measures are fairly similar. In terms of mood, this particular cohort, which is a physio-led program, don't tend to have high baseline levels of anxiety or depression. So we decided to run a pilot project of pre-recording videos, which would be emailed out to participants in a link, which they would view at home. And we thought if it went well following evaluation, then we would make the materials a little bit stronger in terms of their quality. When I looked at the recovery plan for the service, we had a very large number of patients waiting for pain management programs and slightly fewer waiting for Get Back Active. But because of the skill mix of clinicians that were left after redeployment, I thought delivering in this format would be the best thing for the service. And also when we did get the multidisciplinary team back together, then we could all focus on pain management programs. And also, as I've already mentioned, the demographics of the participants of Get Back Active seem to map quite nicely onto this style of intervention. So this is the timetable for the program, and we had started with a telephone call with a physiotherapist who outlined how the program would look, how much time they might need each week to work on the program. Participants were emailed specific exercises and also able to ask any questions before starting. And then every 2 weeks, they would receive either a telephone call or video call, depending on preference. And then they would have the next 2 or 3 presentations. There was also a handbook sent out and some further written guidance about exercise or activity. Since we've started this, we're now trialing group feedback review sessions every 2 weeks on Microsoft Teams. And the first one was today, and the participants said they really valued being able to see the therapist and the other participants. If people choose not to come into the group, they could still have individual calls. So this is just one of the slides just to show you what a participant might see. we pre-recorded this on a PowerPoint presentation, which we then made into MP4 films that people could watch on a phone, tablet, or computer. So since we started this, there have been various challenges that have come up. So firstly, questionnaire completion has been a little bit patchy, although it is improving. There were some issues with compliance, with people saying that they hadn't watched all of the videos, they'd skipped through some of it, even though most of them are between 15 and 25 minutes long. There was some uncertainty with some participants about the movement elements. They weren't quite sure what to do or how to implement it, and a couple of dropouts. So there are 3 physiotherapists, and each physiotherapist is working with between 5 and 8 participants. And one physiotherapist found that about 40% of their cohort were not there at the pre-arranged time for the call, but the other physiotherapists have found compliance quite good. So what we've decided to do is ask participants to complete their questionnaire before their initial phone call. And if it isn't completed, then we would go through the prompts with them on the phone. We've also constructed a timetable, a suggested sort of guide, so that participants can look at how much time they might need to allocate during the week. And also we've made clearer guidance about exercise and movement and put that into a plan that they can record what they've been doing as they go through. And we've decided to ask participants whether they foresee any barriers coming up in the coming weeks that might prevent them from being engaged with the programme. And then we can discuss and problem solve any solutions with them. We particularly wanted to have this tailored type intervention because I must admit I was a bit nervous about offering information that patients just watch on their own, because normally, you know, we understand that didactic information giving isn't necessarily the best to achieve behavioural change. I'm now going to talk about PROMS collection. So I'm going to just go through this sort of step by step because I was unfamiliar with this, but I apologise if I'm preaching to people who already understand this. And I have to acknowledge my colleague, Jonathan Nicholas, who helped me with the technical aspects of this, and also my whole team who've really embraced the change and things that we're doing. So if you sign into Microsoft Teams, those of you that have Microsoft Teams, in a web browser rather than on the app, and then there is this 9-dotted icon. If you click on that, it takes you into Office 365, and then you can get through to Microsoft Forms. So from there you can develop your own forms. We asked participants to consent to participate in service evaluation because they would ordinarily receive this on paper. And I consulted our information governance department for advice and guidance on the wording of this. We also have a button just to agree or disagree about whether they want their PROMS data used in service evaluation, but it is explained to participants that we use that as part of their clinical care and it will go in their medical records anyway. We also highlighted any risk in terms of the data transfer. So we needed to highlight that if they're sending it from their own email accounts, that's associated with third-party provider risk. But once it comes into the Microsoft Teams, that's in a secure place. And lastly, we give information about how to complain if they're not happy, and also to give them information that the data will be stored for a certain period of time and that they can have their data removed at any time they wish. So next, the patient would see the PROMs on the forms. Now, there are obviously issues around this because the way it's presented in Microsoft Forms is not in the same format as the validated questionnaire. So some of you may not be happy with that, but we decided as a service and in consultation with my manager that we would go for this because it's a safe way of data collection and it's very easy to complete. It can be done on a phone, tablet or computer. And this is what the view looks like once participants have completed some of the questionnaires, and you can see that it's visually presented, but also there's an Excel spreadsheet. Now, we are very fortunate that we have a psychology assistant in our team, and she has been helping us enormously with this. So you need someone to check the database, particularly to look at the mood scores, and if anyone is indicating any suicidal intent or ideation, then of course we need to get in touch with them. But also some of the scores need to have means calculated or scores reversed, and then the scores need to go into the patient's medical records. Claire asked me also to just put up the survey that we're going to use to evaluate the remote Get Back Active programme. So these are some of the questions that we are going to ask. And we have asked them to rate the content of each session, because then we won't necessarily have to update every single session depending on feedback. And we're also asking them to rate the materials and how easy it was to follow the guidance, because obviously they're looking at a lot of this on their own. Also, some of the participants were assessed over the phone or via video call before entering into the programme. So it would be helpful for us to understand the method of assessment beforehand. Okay,
Thank you. Yeah. I really appreciate your sharing your experience, and I think a lot of that is really valuable. I'd now like to ask, we are running over time, so it is, I'm just going to keep the webinar running, but I'd like to invite Claire Jacobs to share the questions that have been asked, and perhaps if the panel could maybe turn on their videos, so I can see some questions there regarding the breakout room, which is available via the Zoom platform at the moment. Questions around, obviously, if the clinician was present or not, how long was the session, and I think there's something there about were there people who were dissatisfied with the group environment on virtual or online groups, and how many staff were involved. So is there someone who'd like to take that from the panel? If you could unmute yourself, that would be great.
Shall I go first?
Thanks, Diarmuid.
So we purposely didn't have a clinician in the breakout rooms as an opportunity for participants to share their experiences without that sense of a clinician there. But we normally break them out in pairs. Our breakout sessions are for 8 minutes, and actually Rachel gave really good feedback in the beginning, because I just sent everyone off to a breakout room the first day, I believe, without giving any sense of how long people would be away. So, you know, just tips around telling people how long. We normally go for 8 minutes, so 4 minutes per person to share their experiences and reflections. And actually that question about how many staff, it's definitely a good idea to have at least 2 staff members running any online group, one to do the talking and one to manage the chat and the muting and all of the other things that need to happen when you're running a group online. So that's my contributions there. I've lost the questions now, so I hope I've answered them.
I guess the other thing that might be worth saying is that on Zoom, the breakout rooms are quite automatic. So as a patient, you don't have to do anything to work out how to go back to the main meeting. It's all timed and you're brought back together quite nicely, which works well, I think.
And we've got a nod of agreement there from Rachel. Claire, if I could just ask for this, for the questions again.
Sorry, my screen's gone a little bit. Just try to get that back.
No problem. So in terms of the inclusion criteria for an online program, did people set things out, or did you just call patients regarding whether or not they'd like to attend?
Hi, it's Rob from Chelsea and Westminster Hospital here. We obviously had multiple waiting lists for face-to-face programs and other face-to-face interventions, so that is still part of the process in terms of managing that. Part of the kind of going back a step was to set up somewhat of a kind of an SOP and a pathway before kind of thinking about putting people straight into programs. So ensuring that people go through the pathway correctly in terms of attending a virtual pain information session, and then attending a dual physiotherapy and psychology assessment, and with the proms as well, to ensure that we're ensuring proper information gathering and that this is indeed the correct pathway and treatment for the individual. And so it's important to have set criteria or inclusion processes for people, and part of that, unfortunately, at the moment has been the limitations of some cohorts of people with persistent pain being able to attend virtual programs using the technology, having the right software, having the right hardware, and kind of language barriers and things moving forwards.
That's really helpful, Rob. Does anyone else have anything to add there regarding inclusion criteria?
I think I was thinking more specifically for online rather than, so we have obviously our, like Rob has explained, for pain management programs, but for online, I think we very much taken a pragmatic approach. So I think Sam is on the line somewhere, and Rachel, our teams have rang people who are due to start programs or due to be offered and asked them would they be willing to try online. And one of the things that I think Rachel and the PPSG and others fed back to us was that it was important not to set this up as a people choose this and then they are not offered face-to-face should that ever be a possibility in the future again. So it was not setting it up as if you do this you then will be discharged at the end, but rather a choice to try this as something they could try out now, and then we will be evaluating at the end if people wish to then be offered in person when and if that becomes available again, or one-to-one on video call and stuff like that. But it was quite pragmatic, calling people, getting a sense if they were willing to join and if they were comfortable with using video technology.
And I think pragmatism is going to play a large role in the coming weeks and months. Thank you. So how easy, this is a question for everyone, how easy is it to pick up in order to monitor avoidance in a movement session? If somebody would like to address that.
Yeah, I can comment again. It's Rob from Chelsea and Westminster Hospital. I think that once again is thinking about the type of platform that you're using. First of all, so people have mentioned different platforms, like Microsoft Teams, Zoom, and Attend Anywhere. And as kind of like from Diarmuid from UCLH and ourselves at Chelsea, Attend Anywhere as a group-based platform hasn't been very helpful. But Zoom has the added benefit to one degree of being able to have multiple people in the session and a good connection. But the downfall of that is the more people that you put into a session for a group exercise program like yoga, in my instance, is that the more difficult it is to monitor multiple people, especially if you're starting to get lots of smaller thumbnails, and depending on the device, whether they're all on the same screen at the same time. It is still possible. You still do have a view of them, and that's why it can be really helpful to have a co-host as well who's keeping their eye on the participants of the program. And once again, thinking of the limitations of the camera angles, because you might have a good camera angle and have thought very hard about how you might set up your session so that they can see you at all times and hear you at all times, but it can be very variable in terms of the individuals that you're teaching. So a bit of pre-work on that is kind of helpful. Things like the meet and greet session can be helpful, and getting them to change the view of their camera throughout. And so it is possible in summary, but there are limitations to it.
Maybe I'd add, I guess I'm thinking, I'm interested in this from as a physio working in pain management, how we tend to be less concerned with the quality of the movement and more about the willingness to engage with movement and activity. And so in that sense, we haven't noticed any huge barrier in perhaps not seeing the whole person. We can see people are present with us and willing to try it out. And I guess during our discussion, and that we might explore if people are, you know, noticing that, for example, a certain movement or activity might be something they don't want to engage in. So we just talk about all the options that might be available in that moment. So it hasn't been an issue. And even talking to, again, mentioning Rachel and Joe, apologies, who run our online exercise group, I think there was some, I think it's fair to say, anxiety in the beginning about running that, but we were chatting about this last week in the feedback on how actually it's been really interesting to see people trying things out, moving around their homes, trying things out at their kitchen worktop or in the bath, just to get a sense of how people are doing things, or using the stairs as an exercise aid. We have had a chat about perhaps considering what you might do. It hasn't happened to us yet, thankfully, but maybe what you might do, what your process would be should you observe somebody, say, falling over on the video, and making sure that we're all aware of, you know, the things we would do, call an ambulance or whatever it might be. So having that process agreed in place beforehand, should you ever need it. But I guess by virtue of the way we work with people, that hopefully is would be a rare risk, but it's not impossible.
Thank you so much for sharing. I am going to bring the webinar to a close just now, because that's an hour and 45 minutes that we've been on. So I would just like to thank all the speakers for being so generous with their experience, with their learning, and with the resources that they have used over the past 11 weeks. I've been redeployed, and I can just say that I'm going back to pain management services on Monday, and I feel a lot more confident and very motivated to start setting up our own program in my local area. So thank you all so much to the clinicians and to Tina and Rachel for joining us. It's been incredibly helpful, and I really appreciate you sharing your time. And thank you to everyone who's been listening and commenting on the chat. We will try and pick up a few extra questions and post them on the website if we can. That's great. I'll bring it to a close now. Thank you all so much.